taking us through today's topic. I'm not sure if Mr. Mahlangu is ready to share the screen from his side, but Mr. Mahlangu will be taking us through neuropathic pain management in palliative care. Please share the screen, Mr. Mahlangu.
Okay. Thank you. Let me try to do so. Thank you so much, colleagues, for joining us today. We hope others would join us along the way. Let me first apologize that today we didn't have Professor Wilson Akunda from the Hospice Africa team as we had Diana last session. We have been engaging the professor, so today he had doubled bookings. So he is a lecturer, so today he has a critical lecture to attend, so he couldn't attend our session. Otherwise, we are still waiting to have others to join us. And then, so he said he's apologizing so much for not honoring our session today due to being a busy professor. But then we will continue to look at the presentation and look at some concept under neuropathic pain. Otherwise, in our following session, we are looking forward to have Dr. Eddie Mwebesa from Hospice Africa, Uganda. So brace yourself also to be there as we are approaching to close this page, these few months that are coming. So we will have them to take us through, especially on these critical issues that we need to look closer as a team in palliative care. I don't know if you can be able to see the screen, but I'm trying all the best to share it. I don't know if you can see it now. I don't know. Do you see the screen?
Good day.
Yeah.
Okay, thank you. So on the issue of our guests, that those are the apologies I need to share with you, team. They did share the apologies with us. So I'm very sorry that they didn't make it. But they promised that Dr. Mwebesa will be available on the 25th. But then we are hoping we'll still continue with the presentation. So today we are looking at neuropathic pain management in palliative care. So if you will remember, when we started the session, we're on the page on non-pharmacological and pharmacological pain, we looked at the issues of pain description and then the classification of pain. Then we said there's a somatic, visceral, and neuropathic pain. So now we are looking around on the neuropathic pain. The reason we are looking around neuropathic pain is because it's one of the difficult pain to deal with under palliative care. So we are saying now that we have these principles we have been discussing on pain management, how can we apply them when it comes to neuropathic pain? Last week, Dr. Diana, or our nurse from Hospice Africa, Diana, shared with us on how we deal with incident and breakthrough pain. So today we are looking at that. And then on our next session, we'll be looking around on the issues of psychogenic, if not mistaken, together with phantom pain. So we are now looking at this very to deal with pain with using the principles that we have. So today we are seeking to improve our understanding of pain management by helping clinicians assess and manage neuropathic pain for the different patients that we have, and describing protocol for prescribing pain medication. So we'll look at the protocol. Actually, it's a revision to say then what's the protocol when we are prescribing pain medication. So we do have our national palliative care guidelines developed in 2018 or published in 2018. Neuropathic pain in those guidelines is described as pain that arises when the nervous system is not working properly due to disease or injury. So when the nervous system is malfunctioning due to a disease or injury, it might be cancer, it might be stroke or any injury, then we are saying that one is neuropathic pain. It also says that this pain does not arise in response to any specific circumstances or outside stimulus. Sometimes this pain will just happen not in response to any specific circumstance that you can say this is the initial issue that is making this pain to result. And then also, but the ISP describe pain or define pain as an initiated or caused by a lesion or dysfunction in the nervous system. When there is a is caused when there's a lesion or a dysfunction in the nervous system, then this pain will come. Actually, this is a pain that comes with nervous system excitability. So it has to deal with pain on the nerves. As we said that visceral is in the internal organs, then somatic is when the bones or the muscle. So it's when those issues are touched, then we say that one is somatic. But then it has to deal with the nervous system, and then that pain will be called neuropathic pain. So there are things that we need to understand when we are assessing pain. We mentioned these principles when we were talking about pain assessment last year when we started the page. But there are 4 things we have to look closer when we are doing pain assessment. The first one is the characteristics of pain. When we talk of the characteristics of pain, we talk of the onset, the duration, the location and distribution, quality, intensity, aggravating and the relieving factors, associated features or secondary signs and symptoms. We are looking about also the associated factors, maybe the mood or emotional distress and functional activities that are associated with the pain. So then now we are talking about the characteristics of pain. Pain is not just the pain score 7 over 10 or 10 over 10 or just being severe. It's the whole description around the pain itself. What's the quality? Is this somatic? Is this neuropathic? Is this visceral? The intensity, the location, where is it located? Is it pain that is moving or is it a localized pain? So we need to come up with relieving and aggravating factors so we can be able to manage that pain. So those are the characteristics of pain. So we need to know the pain behavior. How is this pain behaving? And all these features help us to know how best we can manage this pain. If this type of the characteristics of pain is not well captured from the patient, it leads to mismanagement of that pain. And then we also have what we call the functional impact of the pain. When we are looking at under the perspective of palliative care, we then move to see then what is the functional impact of the pain on the patient functionality. So you will find that the patient has pain and is unable to eat, to socialize. So, what has been the impact of this patient on his or her function? So that one is very critical to capture when we are doing your pain assessment, because that one will also inform the issues of the total comprehensive pain assessment, because you will find that it goes to a level whereby it results to depression, it leads to spiritual distress, it leads to social distress. So there's a lot that comes with it. So the best way is to also consider the functional impact of the pain that the patient has. What has its impact be on the function? At hospice and home, they have what they call the ECOG functionality scaling. So whereby they are able to see how much functionality the patient has gone down or has improved. And then we also look around also on treatment responses. When we're assessing the pain, also look at a treatment response of the pain. Actually, what we are doing here, you are trying to see how has the pain responded to previous treatments or therapies. So that's what you are trying to find out. So normally you find that whenever there is pain, there is a non-pharmacological intervention the patient will try to do, or there is a pharmacological intervention that the patient will try to do. If then it's a reassessment or a follow-up, you'll find that there is a prescription of non-pharmacological prescription or pharmacological that was made for the patient. So it's very critical then to ascertain how has the patient's pain responded to those therapies that were provided before you, because it helps you to know what to do now or what to reinforce and what to remove, even what therapies you need to change. And then also what we do on when there's pain with the patient, we do what we call physical examination and then document review. So you also conduct your own either comprehensive or focused examination to ascertain the cause of the problem and to ascertain the impact of the problem. And then also we do what we call document review. That's why in palliative care, special, I was mentioning that one. Without thorough communication between the clinicians alone and between the clinicians and the patient, there will be always under treatment or under management of those patients. So that's why we have to document clearly what exactly was done for the patient so that we can be able to know what to do and what to continue with and what to discontinue based on the treatment. So that one will inform you so that you can't give one the same medication to a patient that is not working. Once that happens, it's a sign that maybe our communication as clinicians is not working or we are not doing thorough documentation for that patient. So that's what we need to understand when we are also moving with neuropathic pain. There's nothing much different from these principles. So there are possible descriptors of neuropathic pain that we know. I know we know a lot as clinicians on this area that it comes with numbness, tingling, burning. It either comes with peripheral pains, like what is parastatic, meaning, or is it paroxysmal, which is a sudden pain that comes suddenly and so painful as letting electric like. They will say it is shooting, they will say deep, dull, bone-like ache. So it comes in different presentations. So, but most of the time, as you say, that it comes with tingling, niggly-like, burning, numbness. Those are the common presentations that the patient will be feeling. Normally, the symptoms will be allodynia, which is pain from stimulus that does not normally evoke pain. You will find that just from the sunlight heat, the patient will be feeling excessive pain, or even from just mechanical touch, the patient will be experiencing a severe pain. So that one will happen with neuropathic pain. And also we have what we call hyperalgesia. We talked about this in the previous one. So it can be exaggerated response to normal painful stimulus. So yes, this one was supposed to be very painful, but the pain was too high than we could expect that one to be. So also that one will show that this patient is experiencing a central nerve or neuropathic pain or a nervous system pain. So the classification of nervous system, we will remember that we have central pain, and then we have peripheral pain, and then we have sympathetic pain. I've put sympathetic pain here because it is also stated in our National Palliative Care Guidelines. So it is otherwise the bigger classes are central and peripheral pain, and the most common one is the peripheral pain. So we will have more patients who suffer peripheral pain, especially from the data that we have from hospice at home. Most of the patients, they are at high risk of developing peripheral pain. So this is what we have. So when we are looking at what they are in details. So when we talk of central pain, we talk of pain that involves the brain and the spinal cord. So it just goes around the central nervous system. So it's just the brain and the spinal cord. So it just move around the brain to the horn and then the brain to the horn. So it goes like that way. And then when we talk of the peripheral pain, then this is the pain that moves to the peripheral nervous system. So it goes down to the legs, the extremities, to the toes, under the feet, the hands. So that one goes to the peripheral nerves. And then when we talk of the sympathetic, we say that this is the pain that is dependent on activity in the sympathetic nervous system. So this one is dependent on what activity is being done. So this one can be anywhere, but it depends on what activity then is being done on the patient. So what normally are the causes of these different pains? So the normal cause, you will find that the common, you will find that patients with stroke, patients with brain or spinal cord trauma, and patients with epilepsy, Parkinson's disease. I've just mentioned the patients that we have at hospice at home here that normally present with central pain. You will find that they would experience central pain, this patient. So then now you will know how you can manage their pain if then other means have not worked for. So this patient, they commonly present with a central pain. And then we have patient with the peripheral pain, the pain that goes to the peripheral nerves. We have patient with the systemic diseases, especially diabetes mellitus, hypertension. You see, those systemic diseases, they put those patients at high risk of developing systemic diseases. I don't know if we've met them and they're complaining of pain. You'll find them the neuropathic pain, complaining of nuclei, complaining of numbness. You know, especially our clients with hypertension. These are the prone patients that we normally have here. And then we have drug-induced disorders, especially we talk of radiotherapy or chemotherapy neuropathy-induced pain or chemotherapy-induced neuropathy. So you find that the person is taking chemo, then is experiencing some neuropathy or some pain, and then we will know it is been induced by that drug that we are giving the patient. And then we have what we call metabolic and nutritional disorders. So when you talk of metabolic and nutritional disorders, you will find that the patient is taking alcohol. So then we will have alcohol neuropathy. You have heard of people who are taking certain drugs or taking alcohol. They will end up experiencing neuropathy, especially peripheral neuropathy. They will feel numb in their toes and stuff because then the alcohol or those drugs they are taking, they've been destroying those peripheral nerves. And then we have the traumatic syndromes. And then under sympathetic, it can be sprains. If you are walking, then you suffer a sprain, or then we have fractures, we have surgeries. Once an operation was done, then the patient, after the operation, will be experiencing that sympathetic pain, or there's been a damage to the blood vessel or certain brain injury. So this one, as I mentioned, it's based on a certain activity that is stimulated that activity. And then we have these symptoms that will normally present on this. If you look around this table, the symptoms, they look alike. For example, when it's central pain, there will be burning sensation, uncomfortable cold, prickling, tingling, pins and needles, stabbing, shooting, lacerating, tight swollen. So they will be saying squeezing that are the squeezes that are sensations that are distressing. They will say a lot of things around this symptom. But then if it's peripheral, the first thing that is there is that it depends, the symptoms depends on the peripheral nerve that is being affected. So it cannot be just anywhere, but it depends on what the nerve is being affected. For example, you may feel that they will have unusual sensation, pain from light touch, muscle cramping, excess sweating, heat intolerance, burning numbness, twitching, getting full quickly, impotence. You know, if a patient has impotence, you'll find that they're experiencing this type of pain, tingling, balance problems. Sometimes they have a lot of falls, they cannot stand. Or sometimes they will experience orthostatic hypertension. So it depends on which nerve has been affected. Then under sympathetic pain, you'll find that there's severe burning sensation in the extremities. Sometimes they have hypersensitivity to the affected area, on touch with discoloring. So you will see that on those patients. And then abnormal sweating, altered temperature, swelling, aching in the affected area. So you will find that this is how it presents as sympathetic pain. So, yeah. What is happening? Okay. And then we have what we call the non-pharmacological interventions or options we can have towards managing this type of pain. Remember the protocol of pain management start with non-pharmacological and then move. But then depending on the pain you are dealing with. Then under non-pharmacological as a supplement to your pharmacological, you can include exercise. So exercise improves the tone and reduce symptom of neuropathy. So if you encourage our patients to exercise. So one of the maladaptive behaviors the patient they will say that I lock myself in and sleep the whole day. That one is one of the signs. If you're assessing your patient in terms of adaptivity, once the patient says, I sleep on my bed, don't leave the house, then you know that's a maladaptive response. You need to help the patient move to adaptive response, engage people, be sociable, have some time to walk around, you know. So sometimes you will require maybe to do CBT or you will need to do motivational interview to move this patient from this maladaptive behavior to adaptive behavior so that you can improve the patient. Then another thing we need to look closer is dietary changes. We look for hyper diet food, antioxidant rich food like fishy and other stuffs that reduce and eliminate. We say reduce or eliminate alcohol intake, except that alcohol is a high risk behavior in terms of opioid treatment. It also exacerbates the issue of neuropathy. As we say, we can have alcohol-induced neuropathy. So we have to eliminate alcohol from our patients. So we have to work with them on how best they can reduce or totally eliminate alcohol intake. And then another issue that we need to do is to encourage our patients to quit smoking. So when we encourage them to quit smoking, because smoking also has a high risk for peripheral neuropathy. So if you have a patient who's taking alcohol together with smoking, except that these are high risk towards opioid users, we've been discussing that one in chronic pain management and even in the principles of pain management. These two are very dangerous. We need to encourage our patient to wean them off or even to go through rehabilitation if it's possible to stop it. And then we can also go towards vitamins, encourage our patient to take vitamins like B complex vitamin, B6, B12, and vitamins E, etc. Those will help deal with neuropathic pain. And then also we can talk of relaxation techniques that are good or the patient can take. And normally the patient will lead you through which one he can prefer. And then we have guided image, yoga and stuff, meditation. You know, we have many things they can do to just relax and sit down. You know, can have those alternative medicines like acupuncture. Last time we have a colleague who shared that it is done around in Zuluini in the country, some Chinese shop, whatever there. So even if they prefer those things, we can recommend those things for them as supplementary treatment that is non-pharmacological. And then we have pharmacological treatments. So under pharmacological management, we have different treatments that we can use. We have one. It can be categorized into 3 classes. So there's the first class that we can try. If it fails, you move towards second class, then you go to third class. All right. So the first class has to deal with the carotenoids or triclic and the serotonin and epinephrine, the uptake inhibitors, the SNRIs, or the anticonvulsants or carotenoids like gabapentin and carbamazepine. So you can try this, or amitriptyline. You can use amitriptyline, so you can go up to 10 to 75 And we have to then, when we are giving these therapies or these treatments, we have to be very watchful of the side effects of those drugs on the patient. We can have other drugs like Eswatini, depending on the patient response and availability. But the most common we find that is most available is the amitriptyline. So we can start with those ones. But when we are giving these drugs like amitriptyline, we have to be very cautious of suicidal ideations and stuff, because this patient can commit suicide. And for the elderly ones, especially amitriptyline, you'll find that it comes with urine retention. Then it becomes a problem. And when we talk of the SNRIs, we have to talk of the issues of hypertension and other issues. So we need to know how then do we manage our patients. So if we talk of the anticoagulants, you'll find that patients will then gain weight, then we have blood version. So, you know, we need to monitor and see which benefits the patient the most. But then if the patient is not responding very well to the first class, then you can add, because if you will not close the first class medication under the WHO ladder that we discussed initially in our session, it's about the adjuvant. We call them the adjuvant to pain management. So you can start with that adjuvant, as it's stated here. If the patient is not responding to this adjuvant, the first class, under neuropathic pain, then you will add the weak opioid. So in the country, we have tramadol, which is between 50 to 400 milligrams a day. When we are prescribing a tramadol, you need to be cautious of seizures. You need to be cautious of nausea and vomiting, itching like other opioids it will do. So we have to monitor our patients very closely for that. But otherwise, if then you can add, let me make an example. I've initiated amitriptyline for this neuropathic pain. It has not responded well. Then I will add maybe tramadol on that. Or I will just give my patient tramadol. If it's not still working, then I'll put in the amitriptyline as an adjuvant to manage that. Sometimes we have topical treatment like lignocaine treatment. So you'll find that they will get it as a gel or as a patch, and then they will put it there as a treatment, so it continually soothes those nerves. And then if this one is not working, we have the strong opioids, the fentanyl, the morphine. But in our country, most of the time, our patient has access both to immediate release and then extended release of morphine, which is the tablet and the liquid. So we'll then initiate our patients to morphine. Remember, you cannot give strong opioids together with opioids. So if I'm moving my patient from the second class, I move to the third class with morphine, I need to remove the third class. But I can give my patient the strong opioids together with the first class. So we need to understand that I can give the strong opioids together with the first class. So I can do that combination, but I need to be cautious in terms of sedation, lethargy, because even opioids, they do that. So we need to monitor our patient very close when we're doing that. And remember, whenever there's an opioid given, constipation is there, and we need to provide what we call laxative. And usually we recommend that we give dual laxative, which is a stool pusher, which is our bisacodyl, or what do we call this? Sena. Yeah, we give like bisacodyl or Sena then with the liquid paraffin or lactulose to avoid our patient developing piles. And then we have these pharmacological agents, as I've mentioned, they affect the pain in different ways. So I'm just sharing here on how this can affect the pain. So we say the pain is one that is in the central nervous system, which is the central pain, and then we have the peripheral sensitization. So these are the areas that we normally look closer. So when we talk of descent modulation, we talk of pain that then now is coming from the brain out of interpretation back to the dorsal horn or in the spine. So when the pain is around the central pain, normally, when the pain is around the central pain, here, when you then want to block it from being interpreted from the brain to the dorsal horn, so what you do there, you can give the anticonvulsants, the opioid, or the tricyclic. So these ones can work. So either the tricyclic or the SNRI, antidepressants, they work very well when the pain is around the central nervous system. When we are blocking it from being interpreted back to the dorsal horn, when it's not transmitted to the dorsal horn, then you can give the anticonvulsant or opioids. Okay, but then once, if you are blocking it down around the dorsal horn before it reach the peripheral nervous system, you can also give the central sensitization. You can give the anticonvulsants, again, opioids, or NMDA receptors, and then or tricyclic antidepressants. So you can give the amitriptyline here. If you look across here, the anticonvulsant, the tricyclic and the anticonvulsant, they cut across all the levels of the pain. So it makes the drugs like amitriptyline, the carbamazepine, the good drugs to give. But then once it's in the peripheral level, you will add your local anesthetic or topical analgesia there, the lignocaine stuff. So you can add it there. And then you can have the others like opioids and then the tricyclic antidepressant and stuff. Otherwise, when it is central, you cannot give the lignocaine. That's the difference. You can't give the topical ones when it's centrally located, when it's the central nervous system that is affected. You can't give the topical and the local anesthetic. It's gonna not work very well. But then if it's towards the peripheral, it's better to give these drugs there. Okay. Then maybe to share with you the structured protocol to choose the right pain medication for your patient. This is the protocol you need to follow every time you are trying to prescribe a certain drug. The first thing we need to do, we have been treating this actually across the sessions. We've been looking this. Sometimes we unpacked it in previous sessions, but now I'm just sharing with you so that you can remember, those who have been with us for a long time, that we need to complete the pain assessment, do the comprehensive pain assessment thoroughly, and then ensure that you match the drug that you have to the pain type. You know, if it is a neuropathic pain, know that now I need my amitriptyline to give for this patient. Maybe I need morphine, I need what exactly do you need? So that you cannot continue for a long time giving a patient a certain drug that is not working for your patient. And then we also look at consider risk and side effects of that drug that you are giving. So always when you are prescribing that drug, consider the risk and side effects. What side effects that drug have? So you need to consider those things when you are doing that. And then also when you're doing that in our previous sessions, we mentioned that always weighing between the benefits and the side effects. Remember that our goal in palliative care is not to cause harm to the patient, but is to relieve suffering and improve the quality of life. Then assess the safest route for that patient. You see, you will find that the patient is now not okay. So you need to find the safest route. Either it's oral, is it transdermal, is it gonna work when it's PO? But then when we are saying in palliative care, the preferred route, it's PO, it's by the mouth. Those are the principles of palliative care, that when you're giving a drug, give it by the mouth and by the patient. Consider who will administer the medication. You know, most of the patients that we have, they stay at home. When we are giving certain drugs, look at the caregiver. How much competent is the caregiver in giving that medication? And then determine whether the patient can find or afford the drug, especially teams like Cyprian's team that is in Babane. and then we have seen a patient from Navumisa. So you need to ascertain if they do have in Matangeni the same drug you are prescribing for the patient, so the patient can refer the local area, so that you don't give a drug that is no longer there. So we need to look around those issues, then assess the cultural, spiritual, social context for that pain, because most of the time the cultural and spiritual and social context have a very impact or role in pain management. So we need to consider those issues when we are providing our patient. I think that's what we can share concerning a neuropathic pain. If you will note the stages that we go through neuropathic pain is a little bit different from the natural way of pain management in the pain ladder, which we just say take analgesic, then with opioid, then later to morphine. Here we say first step, take convulsants or gabinoids, and then goes to weak opioids, then strong opioids. I think that's what we need to look closer here, that in the natural pain, like somatic and that pain, the ladder that we know, it means in the first class, it talks about Panado, Brufen and stuff. Then second class, it talks about the weak opioids, as it's saying here. And then it then talks about the issues of strong opioids. So there's the first, the analgesic level, then the weak opioids and then strong opioids. But in neuropathic pain, we talk of the first class, which will be anticonvulsants, tricyclic and serotonin and SNRIs as your first class in terms of treatment for this type of pain. So we need to note that. And sometimes they don't start you in Panado, they start you in these drugs. Then if they fail, they move you to weak opioids, then strong opioids. So I think that's what I will say we need to note from this one. Thank you.
Thank you, Mr. Mahlangu, for the lovely and insightful presentation. I believe that we were all able to follow through, and I am happy to see that other colleagues were joining us as the session was continuing. So at this point, colleagues, we will probably give an opportunity to anyone that wants to ask any questions based on the presentation, or if there's any comments that we would like to make before we move to our case presentation. Do we have any questions or comments for Mr. Mahlangu? We can use the chat box, or we can use the raise of hand. Okay, we are seeing comments that are appreciating the presentation from Mr. Mahlangu. Do you have any questions for him?
Maybe to add, Messi, as the colleagues are still thinking of any contribution, I will say that we need to understand that, these drugs, sometimes you'll find that in facilities, some will require doctor's prescription. I think you can see the classes there. Some will need you to consult. The best way to say that, let me make an example in a clinic. You will find that maybe you don't have these drugs in a clinic, and so it's to advocate for the patient. If it's in a ward, you need to do your assessment, then you advocate for that. The issue is that doctors sometimes will, not because that they will forget. It's just that maybe they are busy, or they are not always able to have enough time for the patient. So the critical issue is to do your thorough assessment, especially to ascertain the type of pain the patient is going through, because you will continually give your patient Panado, and if you will be giving low dose of amitriptyline, the 12.5 milligram, because in the country of the 25 one. So if you will give your 12.5 milligram, it will be far better than giving a Panado. And remember, these drugs sometimes they are given nocte, so you will need the medical advice on terms of how much should I give. And remember, from class 1 to the last class, they have really severe effects, and especially to our special population, which are the elderly ones. we need to be very critical when it comes to those guys.
Thank you, Mr. Mahlangu, for the addition. I think in the absence of questions, we can move to our case presentation. I'm not sure if Thandazile is ready to share the presentation with us, but we can also share it from our side.
Good afternoon, Macy and team.
Afternoon, Thandazile.
Please kindly share from your side. I'm still trying to switch from my phone here and using a laptop. I was trying to be a bit economic.
Okay. Is it visible on your side?
Yeah, it's showing. It's showing. Just a second.
Okay.
All right. I think we're good to go. Otherwise, once again, team, good afternoon. It's Thandazile Smelane from Manzini Government Hospital. I was hoping that the other colleagues would actually join, but apparently they're not. They're still not with us here. So in that case, I will continue anyway. We tried to get a case that would actually kind of illustrate or kind of relate to our previous main topic today to cover up for that, but unfortunately we couldn't, so we looked for something that was closest to it, which basically covers, it's basically somatic pain. So yes, we have a 25-year-old male with a diagnosis of osteosarcoma and with stage 4B on the left scapula. So yes, on the CT scan, it showed multiple infiltration and also multiple nodules on both lungs, left and right. So yes, there is metastasis to the lungs. Then what was our main concern regarding this client? Our main concern was uncontrolled pain vis-a-vis client's wish. So this client was complaining of severe pain. Like the first time he actually presented to the facility, he was a client who was complaining of severe pain on the left shoulder and had a very big mass, which also would affect his mobility and function. And on history taking, we discovered that the client had actually been doing follow-ups in South Africa, but then he didn't bring much documents this side. So then he later showed up in one of our facilities as a new case. Then they did other investigations, which later confirmed that indeed it is osteosarcoma. Then the kind of pain that the client has, like I said, it is somatic pain because it is in the bone. It's musculoskeletal and it's chronic. It's pain that doesn't go away, and it's pain that he can actually not kind of associate with any incident. It's mostly there most of the time, and it's on the left scapula. It sometimes radiates to the entire left arm. Pain intensity is between 7 and 10, and it is actually mostly there. Like any time of the day, it's mostly there. It's chronic pain, and yes, a bit of activity would aggravate the pain, and a bit of moving of the left arm, bit of activity, yes, it would aggravate the pain. And there were no relieving factors associated to this kind of pain. The client would always say the pain is actually always there, and he hasn't figured out anything that actually brings a relief. Yes, it does affect his functional status. Client has been put on morphine, has been put on paracetamol and other NSAIDs, obviously, but Unfortunately, the client is just reluctant to take the medication. So on physical assessment, yes, there is that huge and painful mass on his left scapula, and it also affects his mobility. Then psychological aspects, the client is actually angry about a number of things. There is quite a lot that happened around his while he was a teenager. He lost his mom, and apparently the family was divided into two, and ultimately the father decided to sell his mother's home. So as it stands, the client would move from one place to another, would stay with grandma, would stay with uncle and all that. So the client is kind of very angry and has so much resentment towards his father. He also feels like alienated. He also feels like he would express that sometimes he feels like he's more of a charity case, yet ordinarily he's supposed to be having probably a stable home, as his mother had actually left him at least a roof on top of his head. And he's one client who's not trusting much, because even with the relatives who would actually come visit him, come see him, they would probably sometimes bring him food and other stuff to eat, apart from the food that we provide as a facility. But the client wouldn't touch any of those. And he would actually verbalize that he actually doesn't trust anyone. He's not sure what is really going on. And we were, yet on the other side, we were hoping that this is the kind of, like, this is the only support that we could have for him. But the client was like, they're fine, they're here, but I don't trust them at this point. At some point, the client would verbalize that he feels like it's better for him to be left to die in the hospital than going back and face the reality of being a beggar and face the reality of being a charity case, and having relatives discussing where to take him and who is going to kind of take care of him and all that. He felt like he's better off left alone in the hospital and just die there. He's one person who survived through casual jobs. He would do part-time jobs. There wasn't anything specific, no occupation that was like really specific. He would do whatever that comes his way. And yes, he's a Form 5 leaver. And for us, working class doesn't necessarily mean that you are actually working, but anyone who actually contributes to the economy of the country, then we classify that one as working class. That is why we put him on working class. He is single, and he's one person who said he never took any form of substance. And he doesn't have really much information about any relevant health conditions related to his family. Other social related information: yes, client lost his mom at around his teenage years. Then his dad sold his mother's home. He had to live with extended family from one place to another. And he no longer wants to go back to live with the other relatives as he used to before. And obviously, according to him, there were estranged relations amongst other family members. But also, one thing that we picked, but it doesn't, we couldn't slot it anyway here. I think, okay, it's the issue of, okay, maybe we'll get to that. Spiritual aspect. He's okay. He says he mostly keeps things to himself, but sometimes he does share things with her sister if he really feels that he's no longer coping. There's a sister that she says, sometimes I do talk to her. He does believe in God, but when you talk to him at that point, the client would tell you that You know, I do believe in God, but I'm really wondering, why would he allow me to go through so much at this age? I'm still young, and right now I'm not so certain about the future. And why would God allow me to go through all that? In fact, when he first showed up in the facility, he was actually told about diagnosis and stage and probably prognosis. Then he decided to go and kind of consult, would I say, and he started doing traditional herbal medication, and the condition got worse. Then the family decided to bring him back to hospital. So at this stage, we figured out that the client is actually, he's kind of confused. He's really struggling to attach or to actually find one or whatever. I don't know how to put it, but to kind of find one or anything that would actually define or bring purpose to him. He's struggling with the traditional one. He's struggling with God. He's struggling with family. He's not sure of himself. He's struggling with a lot of things that are actually going on around his own life. So yes, he does traditional medicines, but at some point he would tell you that it doesn't even relieve him. And another thing, he feels like he's being rejected, and right now he hardly goes to church because of his immobility due to the disease progression. Then significant medical or surgical history. Yes, there is that pain, the mass on the left shoulder, which started around, actually started around 2021. And he says he did treatment in South Africa. Then 2022, he did investigations in Eswatini, and he was confirmed to have cancer. Then 2023, he was referred to Moneni, did palliative chemo, which was ultimately stopped. Then he was also on supportive care concurrently. Then he went to traditional healers. Then he was later brought back to the facility on a very weak condition. Relevant past medication. Okay, the reason we do not have current medication, it's because we ultimately lost our client, but we felt like we need to go through the case so that we can actually have assistance on how best to handle any other like any other like case or similar case. So he was, at some point he was on tramadol. He has been, okay, some of these were prescribed and he never took. So he has been put on tramadol, he has been put on morphine, he has been on bisacordial, and he has been on dexamethasone, prednisolone. He has been on lorazepam, he has been on amitriptyline. He has been on Cipro because at some point the white blood cells are a bit high. He has been on Zometa because of the bone pain. He has been on Neupogen. At some point the neutrophils were a bit low. So he has been on a number of medication. He has been on NSAIDs. He has been on a number of medication. But currently, at that point, the client was a bit difficult because at some point he wouldn't take any of the medication. At some point he would pick, okay, I would take this and not that. But with your opioids, the client was just reluctant to take. He would say for the pain, he's using some herbal medication, but then with follow-up, again, the herbal medication wasn't helping with the pain. So at some point, we really had to try to understand whether, yes, there was that physical pain, that somatic pain, which we clearly understood because of the disease progression. But also, we really had to sit down and actually find out if we are really, for the client, if the actual concern was the physical pain or it was the spiritual and social issues. So we were trying to I don't know, I think we have lost our slide. So while we were trying to work on that, unfortunately, the condition of the client got worse. But in the process, what we were trying to do was to get his grandmom. Are we still together?
Still with you. I think my team has just collapsed. I'm trying to put you back a screen.
Okay. So yes, amongst other things, we were still trying to get the grandmom from the mother's side, because at some point he stayed with the grandmother, and he would say that he would be comfortable being with the grandma, but then the grandmother was staying in South Africa. So we tried to get the uncle involved to get his grandma to come see the client. So amongst other things, the one thing that we picked was that spiritually the client was he felt kind of lost. He felt like he doesn't even know his own identity. He doesn't know who to trust. He doesn't know really who to run to. And at some point he feels like I'm tired being a charity case. At some point he feels like even God has forsaken me. He feels like I've tried consulting, I've tried using traditional or herbal medication. Nothing seems to be working for me. So at some point, the client was a bit depressed. He was anxious, and which is why amongst our medication, you would see lorazepam. So while we were trying to figure out what kind of pain we're really dealing with, now you don't want to expose, because he's not able to actually describe the kind of pain. So now we had to put him on your strong opioids, and also to consider adding adjuvants, including your dexamethasone, including your tricyclic antidepressants. As you can see, we have AMT there. There was a number of other adjuvants which we tried. So he would pick a bit of this and that, but then it became very difficult because he wasn't taking the medication comprehensively. But then at the end of the day, what we picked was that, yes, we are dealing with physical pain, but according to clients' priority, the one thing that had to be dealt with was the spiritual and the social aspect of it. So while we were trying to get at least those people who we felt the client felt like they meant something to him, or they had meaning to him, unfortunately, his condition got worse, and fast we lost the client. But yes, I'm not done. Yes, we're still here. We have information review. Yes, mostly his vitals were around normal ranges, except for the pulse at some point. But yes, mostly his vitals were around normal ranges. Yes, functional status, he was at ECOG 3, because most of the time he was in bed, and most of the time he wasn't able to do a number of daily activities. He would spend most of his time sleeping. So also with the sleeping, you would associate it with disease progression, but also it could have been him trying to escape a reality. Yes. Then we're trying to rank our symptoms here. The pain, according to him, it was severe pain. The physical pain, it was severe pain. Unfortunately, he wasn't so keen to take the medication that we were giving. Then he had no dyspnea. Anxiety, yes, he had moderate anxiety. Agitation was there. Depression was there. Then drowsiness, actually, fatigue was there. Sorry about that. There was fatigue, but there was no nausea and vomiting, no anorexia reported. He was able to eat. No constipation reported, no dry mouth. Then yes, there was poor mobility. Then yes, your labs, we have elevated white blood cells at some points. That's why he was put on antibiotics, including Cipro. And yes, the imaging and special investigations, a CT scan was done, which confirmed osteosarcoma, and there was a lymph node. There were lymph nodes on the left axilla, inguinal areas, retroperitoneum, and other areas, but also there was multiple lung mets. So the further plan, actually, while we had the client, it was us trying to assist the client to understand the disease process, what actually sorry, what actually explains the pain, what actually explains everything that is actually sorry. Sorry about that. What actually explains everything that is going on. Also, the plan was also to further engage the client on the pain management, which was the physical pain, because he wasn't taking the medication as prescribed, but also he was saying the herbal medication he was taking wasn't working, so it wasn't relieving the pain. So the plan was actually further engage him on pain management and other goals of care. Also, we were trying to work around issues of relaxation technique, which was to involve the physiotherapy, but unfortunately we didn't have him around at that time. So we would work around issues of what we usually call pillow technique, just making sure he keeps the extremity elevated, making him comfortable, finding a position that would actually work for him, trying to engage him on, maybe it could be music or anything that would actually try to calm him down. Also, amongst other things, it was getting uncle to get the grandmother come see the client, because he actually felt like he was comfortable with the grandmother around. Then also on the issue of spirituality, yes, he was reluctant to take some of the Western medication. He believes it's African, like it's Maloyo. And he also questions why would God allow him to go through so much pain, all this much pain. So we were trying to work around the issue of spirituality to actually kind of find out what.
What's your issue?
Sorry?
Sorry. Continue.
Oh, okay. Oh, yeah. So at this point, we were still trying to figure out, or trying to find out from him what he really thinks he wanted at that point. So unfortunately, the condition got worse until we lost our client before we managed to crack that one out. But that was the actual plan. So yes, like I was saying, we were dealing with one physical pain, which was a bit complicated to ultimately manage because of a number of factors, including client-related factors, but also we were still struggling to put a finger on it, whether it's really the pain, the physical pain that we were dealing with, or it was spiritual and social issues at play. So at the end of the day, then we felt like, yes, the physical pain is there. We need to continue engaging the client. But then while we were trying to work on the social and the spiritual issues, then we lost our client. I think that would be it for this case. So yeah. Thank you so much. If there will be any questions, unfortunately, the rest of the team is not here yet. I'm not always at work, and they were the ones who were actually handling this case. But yeah, if we do have questions, then I would try to take the ones that I'll be able to.
Thank you, Thandazile, for the case presentation, and thank you, Mr. Mahlangu, for actually taking over. I think we had issues with our laptop and also our connection, but thank you, colleagues. I don't know if we have any questions for Thandazile or any comments on the case. It's a pity that we were lost somewhere. Okay, I'm seeing a hand from Simpiwe Dlamini. Please unmute yourself, Simpiwe.
Thank you, Tim, and thank you, Thandazile, for the presentation. It's not a question per se, it's just a comment. Seeing such cases, because when I try to analyze this case on where exactly the patient was suffering, but I can see that physically there was pain. Probably he was lost because he couldn't point into one thing that he relates and believe. We can see that by moving from starting in hospital and then moving out to do to get traditional remedies and then coming back to hospital and then using again this traditional with the Western medication, which I will dwell on at the latter end of my comments. And then looking, we have talked about physical and spiritual. Also socially, everything was not going well with our client because he ended up feeling like a charity case, meaning moving from one guardian to the other and has no stable relationships with whosoever is staying with at all. And also looking at the economic or financial status, that this client of ours was not permanently employed. We don't get history or information that he was working and is having Boma pension or disability support, blah, 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 which means the client is also struggling financially. And all that, it adds up to him being emotionally unstable, because he would want to take some of the medication at times and at times not, because of whatever that this client of ours is going through. My big concern is how do we balance the support we give to the client? I'm looking at, if we were talking about only Western medication, I would say I'm looking at drug to drug interaction. But here it's drug to timbita interaction or traditional medication. To say, how do we balance accepting or supporting the client in these stages of pain? To say, how do we draw the limits? To say, okay, we can allow a client, as we are clinician, to use the things that the client believe will work, or that will also cause pain to the client. If we say, no, don't use that, that will not work, blah, blah, blah. How do we balance that? Because we know that sometimes when we use these medications that we are giving to this client, they might interact with any other drugs. They might be traditional drugs or from healers or from what, but that interaction and the drug loads, as well as their excretion, we might be having cases where we give a certain drug which should work at a certain level in the body, to find that the client is taking something that depletes that drug in the system. Then it will appear like the drug is not working for the client, except for the fact that the client is taking something else. So how do we balance that to say we are supporting you in this, we are in your team, but please don't use this and that? Will that not also cause conflict to say they are imposing their beliefs on mine, blah, blah, blah? Thank you for that.
Maybe that one, I know it's not directed to to Manzini government team. It's for everyone, but just to make a comment on what you just raised, Ngozi. I think at some point there was a time where we felt like, as a facility, we are not helping him much because he's not taking our medication. So yes, there were times where we were actually considering discharge. But then unfortunately the condition got worse. Then I'm asking myself, if it had it not been for him getting worse, how best could we have handled that case? So I think it's a concern that we really need to be honest when approaching it. Yes, there are issues of us imposing our beliefs, but also there are a number of other issues that we really need to consider as healthcare givers. So I think I would leave it to the house as well, because it's one of the issues that we still struggling.
Thank you, Thandazile and Simpiwe. I think, like Thandazile said, it is something that we can actually all discuss. It's not only a question posed on Manzini Government Hospital. I am seeing a hand from Nombumelelo. I am not sure if she wants to probably respond to what Simpiwe was saying, or she has a total different comment or question, but let's hear from Nombumelelo before we go back to what Simpiwe said. Kindly unmute yourself, Nkosi.
Hello.
Hello, Nkosi.
Yes, thank you very much, Mahlangu. Thank you, Thandazile, for the case presentation. Yeah, it is an eye-opening one. Talk about holistic pain. This pain, because you can see that even psychosocially, he was suffering. When we are looking at the all the facts that our brother has been, yeah, it would look like we are. It will be it's always up to the patients to decide on what they want to do at a point in time. If he wants to take traditional medicines, it is up to him. All is left for us is to explain. And I'm so happy that we all noticed the pain that the patient was suffering. It is a good start for us as healthcare providers to see the kind of pain that our patients are going through. What I think is left is that we advocate for holistic pain control, and we are able to refer where we are supposed to refer when we see that this patient needs some counseling on the issues of spiritual care. We know where to refer our patients to. I think it is about time we talk of collaboration with all the stakeholders with regards to palliative care and the kind of pain that our patients are going through. I think that is what I wanted to say. But I'm happy with the case presentation because it goes hand in hand with the session for today. And I'm also happy that we are all able to identify the kind of pain that our patient was suffering. And I'm so painful. I think that we lost our patient without even going through all that we had planned to do for the patient. Thank you very much.
Thank you. Thank you, Nkosi. I'm seeing a hand from Mr. Mahlangu. Okay, before we go to Mr. Mahlangu, there is a comment from Simpiwe, which states that he is not blaming Manzini government, but instead he is trying to learn from the case. It was a very good case to discuss, and because we see complete pain and holistic pain. Thank you, Simpiwe. Can we move to Mr. Mahlangu?
Sorry, Macy.
Yes,
Yes, maybe before we move to Mr. Mahlangu, I'm assuming he would want to wrap up everything. But we have a concern actually. I know amongst other things, palliative care doesn't seek to hasten death, but then we always have a question, because sometimes when we talk of these, okay, probably amongst other issues, it's the issue of addiction. We fear clients getting addicted, and also probably around regarding today's case, probably the client is taking herb or whatever he was taking, concoctions, and now we are worried about him getting probably electrolytes imbalance and having other organs affected. But we already know this client is actually at the end of life. He's stage 4 and all that. Which one takes priority? Is it what the client really wants, or it's what we think is right for the client?
Okay. Thank you, Thandazile. I think from the beginning of treating the client to the very end of that probably process of caring for the client, it is important to put the client first. And when we are talking of end of life care, it is very important for the client to feel in control of their care, so that they are at ease and they don't feel like there's a lot of things that they need to explain or be concerned about. And also, end of life care is mostly about the client getting as much comfort as they can possibly need. So I think it is very key to prioritize the client first. I think Margaret Dlamini mentioned it, that what is very important is that we actually educate the client first and then allow them to make the decision, but ensuring that they have all the information regarding probably their condition, their treatment and their prognosis and everything, and then we leave it to them to make that decision. And upon having them making that decision, we also support them. We don't make them feel like if ever whatever they're trying out is not going to work out, then they shouldn't come back to us to seek for help, but they should know that we are always there to help them and support them. And if they have any concerns, we will be able to probably talk them through or address those issues. So I think it is important to educate and then support the client. I don't know if then we can probably hand over to Mr. Mahlangu.
Thank you so much.
I don't know if it's...
Okay. Okay, Miss, you're talking?
No, I was checking if you're still here with us. I couldn't see, but it's okay. Please continue.
Okay. Thank you so much, team. Yeah. This one is a critical case, and thank you so much, Simpu, to raise these issues. Unfortunately, where I am, already another guy has come, so he's pushing me all over, but let me try to respond very well. This is a typical case at end of life. So most of the spiritual, social, and the ethical issues, they will come up. As Thandazile is saying, when the patient is approaching the end, then which one will take priority? Do we look for what the patient, we will go and work for the patient, or we still follow the patient? Simpwe said, when the issue of team leader and staff. Let me just share a simple story. How would you feel if you will let me stop taking my traditional medicine? By the day I stop taking, then I die. That's the thing that normally happens. So the family will blame you and the patient will die cursing you, I believe. So the best way is to always share the information with the patient and ensure that you don't become biased. I am a Christian, and sometimes I will meet Muslims, or sometimes I will meet traditional people like this one, who sometimes prefer traditional things over Western things. My duty is to provide information, and wherever I think there will be a contraindication, whatever, I share the information so the patient can notice something. So that when the patient has failed to use whatever he's trying to do, he comes back. Reality is, the patient is faced with a war of an illness and he wants to fight it with all that he has. My duty is to support the patient, fight a good fight. Especially for this case, the patient now we know clinically, this patient is going to die. Whether you can bring a 1 million chemo, you can bring a 1 million in this patient is going to die. There is nothing you're gonna do with it. It's cancer metastasizing into the lungs, the patient is going to die. And now the patient is at end of life. The unfortunate part with this patient is that we have just met this patient at end of life. There are critical issues that needs to be discussed while we are still fit. In palliative care, we are encouraging that one, we need to move public health issues. We need to move to public health level the issues of advanced care directives or advanced care planning. If I can ask all of us here, how many of us have already shared what we want to be done on us when we can reach a difficult stage in life? You will find that none of us have said anything to anyone, no document or whatever. And then when we are faced with this situation, there's what we call advanced decision to refuse treatment. A patient can verbally state it or write it down and say, should I reach this stage in my life, I don't want to take morphine. So that one is a decision for the patient. So we need to acknowledge that decision and work with the patient going forward. But then any decision the patient has to take must be informed of the good and the consequences. Then they must make an informed decision. So I will say that these are the issues that normally engulf us at end of life when we have not prepared for them. So these are the issues that normally then defeat us when we are not ready. So we need to engage our patient as early as possible. It's unfortunate on this patient, but now I'm making an example. We have a patient maybe diagnosed with cancer stage 2. And when you're looking at this patient, 3 months or 6 months later, the patient is moving to stage 3. And a few months later or some years later, the patient is moving to stage 4. Those are indicators that this patient is going. So let's not wait until the clouds are dark. Then we begin to talk about a difficult question like this one, where this patient was. So let's start as early as possible to discuss these issues of spirituality. So for this case, I would say really the biggest issue this patient was going through was the spiritual distress. Once you hear a patient saying, why God me? I've tried but that one means this is a spiritual issue. What we need to put then, we need to be more aggressive in building the spiritual life of this patient. Actually, this patient is recognizing that physically is not making any progress anymore. But unfortunately, spiritually, I don't have anywhere to hold on. So that's why then we need to sit down with the patient. We can use the hope model, whereby we find the sources of hope, and then we look at the practices and how best we can support the patient on the practices. If ever the patient is taking traditional medicine, it's good to say, if it works for you, you are free to take it. But we are not sure the impact of this and this and this it will do. But anytime you are free to come back to us to get our medication that we have here, so that the patient can know that you are supporting, even if you don't know how it works. If there's a thing younger that we know, the patient that knows very well can do this thing, we can even facilitate the thing younger to come and meet the patient. So I can say here, there was a lot of spiritual distress. So the hope model will help us getting person who will address the spiritual issues. When the patient feels that God is rejected, then the question is, we know now the person is dying and he will need to hold on something. We will need these motivational interviews. We need those spiritual counseling. We need to be aggressive on that area. Because once the patient's spirituality stands, then you will find that he is able now to get a trust. You will find that he will not only trust the family, but now he will understand. I'm not sure if the patient was aware that he was now going to die. If really he was aware, that was another reaction to say that if I'm going to die, where can I hold on? So I think that one we need to build on. In our study that we have done recently from RFF, we have discovered that the spiritual area is not yet embraced by our facilities, or else as a healthcare facility, we are not embracing it in terms of aggressiveness towards the end of these people. Or we just look at Christianity, the Bible, And we think we have covered everything for the patient. We have never sit down and say, what's your spirituality? I've heard that the patient was refusing to take these Western drugs. There are different issues. Maybe he has just let go of herself. So he doesn't want anything has to do with any medical because it has not done good for him. But then dealing with the spirituality will help us to overcome the issue. All I've seen here is the ethical issues. I will upload you, in hospital, just to remain calm in the storm when you are not sure. If the patient doesn't want these drugs and then we see the need. Actually, the golden rule says that do to others what you will prefer it will be done to you. That's the golden rule. But the challenge with the golden rule is that what if I want to be shoot with a gun when a situation is like that? Then I need to shoot the patient because the golden rule says do to others what you want to do to yourself. But then we have the platinum rule, which says do to others according to what they want it done to them. And that's what we are moving towards to now in palliative care, to say, let's do to the patient to what they prefer, let's do it for them. Especially now in this case, we know they're going to die. So I don't know, maybe counseling. And what I will encourage us is that another issue that is an indicator that a patient is going is the decline on the functionality score. If you are seeing a patient moving towards ECOG 1, 2, 3, it's going down, those are signs that the patient will leave very soon. So the best way is let's discuss end of life issues as early as possible. You know, it's a taboo in our culture. That's why in palliative you need to be aware of your own spiritual and cultural issues. Where do you stand in terms of culture and spirituality? Because at some point we have to discuss these difficult questions. Let me make an example. Today I want us to discuss about death and dying. Once a patient starts the conversation to say, I prefer to die in the hospital, that one is an open room for you to discuss the critical issues of end of life. That's when you will discuss the issues of what the patient will prefer should death comes, what the patient will prefer to, where the patient prefer to die, how the patient will prefer to be cared for should he is not able to do that. It's your open room to discuss this difficult question with the patient, even with the death and dying, even with the issues of whom he wants to be close to him. Do you prefer to have a pastor close to you? Who do you prefer to be with you when you are dying? All those issues we need to discuss because the patient has now opened the door. But you find that then we are withheld by our own issues. I cannot prefer this, but the platinum rule will say, let's pull through and go through. So let me just share that and then emphasize that patient autonomy remains until the patient dies. Even after that, when the patient has said, I don't want my cop to go to Mama School's home, you don't have to do that. The family has to respect that because that's what the patient is expected, you know. So I hope at some point we will have presentations on spirituality and end of life as we continue with our pages, because when we finish this one, we'll go to symptoms. We will approach to these issues. We have shared some ethical issues in the previous sessions, but let me emphasize on that one that say the patient always takes priority in whatever we do. Let's embrace the platinum rule that would say, whatever the patient wants to be taken care of, let's do that, other than the golden rule that says, do to others what you want to be done to you. Let me just say that will be my contribution, team. Otherwise, thank you so much, Manzini Hospital, to such a case. If a patient doesn't want the morphine, our duty is to explain what is the use of morphine only, and then allow the patient to rest in peace. That's what I can share.
Thank you, Mr. Mahlangu. I'll probably take no Pumelelo last because the time is not on our side anymore. Kindly unmute yourself, Nkosi.
Thank you very much, Mr. Mahlangu. While you were talking, I just recognized that us as healthcare workers, we really are lacking in the spirituality part. We are not even sure of ourselves. What is it that we think will be the end of our lives? It is then that I'm thinking maybe we needed to have, we are asking that we may get a lecture on self-spirituality one of these good days. No, not, what can I say? But I'm just hoping that we would have a session that is directed to us as healthcare workers, a session on spirituality, because if we don't recognize the part spirituality plays on palliative care, it will be very difficult for me to take care of somebody else's spirituality, because I don't even understand that part. I don't even know what part it plays in the healthcare of that person. Yeah, thank you very much. By the way, I have learned a lot today. Thank you very much, Manzini. Thank you very much, Tandazile. Thank you, Mr. Matlang. Thank you very much.
Thank you, Nkosi. I believe that has been noted, and as the hub team will probably work on having a session where we talk about spirituality. Colleagues, due to time, can we come to the end of our session? Can we click the feedback link in our chat box so that we can give feedback on today's session? We will be having our next session on the 25th of October, where we'll be looking at phantom and psychogenic pain management in palliative care. Please join us for that session, and also please invite other colleagues to join us so that we can all be able to learn from such cases and from such presentations as we did today. Thank you, colleagues. Do have a lovely afternoon.
Yes, Ziggy talk. Hi, Messi.